right. Welcome everyone to this podcast, video podcast. We're calling it Toe to Toe. The goal is to bring together experts in the field who may or may not agree on everything, but certainly agree on the fundamental things. My name's Hodges Davis. I'll be the moderator here. My two toe-to-toe experts are Justin Kane and Mike Aynardi, and they actually were residents together, been out in practice for 7+ years after their foot and ankle fellowship. And today we're going to talk about complications of neuropathic problems in the foot. So we'll talk about Charcot, we'll talk about fractures, and the goal of this is to say it's time to bring the treatment of this difficult patient population into this millennium. We have so much better options, both surgical and non-surgical, to treat these folks. And so our goal is to have fun with it, but more than anything is to bring the realization that we've got to up our game. We're going to have Justin present cases, and we'll have the professor comment. I'll try to add some segues. But again, fundamentals, keep the fundamentals, looking for stability, treat the infection, and don't let them go too long or else you're going to be doing an amputation.
Right.
So Justin.
So I loved the fact that we went with one peritalar dislocation to another because I think this shows the complete opposite end of the spectrum is what can you do when you get them early. So this is a 74-year-old gentleman, acute onset. He said he was walking his dog, felt a pop in his foot, looked down and his foot was crooked, came to my clinic, and this is the picture that we see. So same thing, his calcaneus is on the side of his talus. He's got a pure peritalar dislocation. He's diabetic, he's neuropathic.
No ulcer.
No ulcer.
Okay.
This is brand new. So here we go again. I mean, we see all this stuff and, just because it's the same, at least radiographically, they're not all the same. And I think we do need to look at these and figure out what's the best.
All right, let's come to some points of agreement, right? Is this going to end well if you leave it alone?
Absolutely not.
Okay, so in theory, he isn't full-blown Charcot. He just had a traumatic event that happens with neuropaths, right? They have different trauma than the rest of us. So do you leave it or do you fix it immediately?
Yeah, that is as close to a surgical emergency in my mind as a tongue type calc. You show me that picture, and fortunately in this patient, you have skin's okay. And so that kind of opens the playbook, if you will, to lots of other options than just ripping out an infected talus. And I'm not sure what Justin is going to do here, but I think going early in this patient is going to keep you out of that first case I showed and keep you out of trouble.
So you're within the first week, I suspect, okay? So you would try to do an open reduction. Would you do a primary arthrodesis?
Yeah, so if I could get this, I don't think you're going to get this reduced closed. And if, God bless you if you could, you're stronger than I am. But I think I'm probably going to try to take some of the talar head, come across tarsal joints, get it reduced. I'd use the fibula for autograft, bone mill that up. I'd prep the ankle and subtalar joint, and I'd try to get a hindfoot nail up, maybe with some supplementary screws in this patient population, just across the subtalar joint.
Sure. TTC fusion.
Yep. And that's
leave
how
the
I'd do this.
tarsal joint. Ideally.
I would. I've had more trouble when I try to go for a true pan-talar in this patient. I think if you're not going to put an X-Fix on and just nail them, you got to protect them with a total contact cast for a long time until they're out of this inflammatory phase. Because I bet you that this isn't a traumatic dislocation. I think this is Charcot in the earliest stages, just like the mice. And this thing was going. This process was a few weeks in the making, and the pop just happened to be a couple drops of water spilled over the sink that's clogged here. And I think this would probably be a good patient for a nail frame combo in my mind.
And Justin, this conversation is going to help you so much because I think if I can give a mice reference one time in my week, and now I have it. I'll be going, well, Mrs. Jones is just like the mice.
Just like the mice in Pennsylvania.
All right. Well, tell us how in Texas with no mice things went.
So again, nothing here steps out as being overtly obvious, except that it's mobile and reducible. And I think that was an important point for me because it was mobile and reducible. And I agree. I think this is early Charcot in the very, very early stages. You sit on this, it's going to be bad. So clearly indicated for surgery and clearly going early is the right thing to do. So my algorithm, I thought there were three things that we could possibly do. Isolated internal fixation, bolts and beams, like we know is tried and true.
So save the ankle.
Save the ankle. Hindfoot arthrodesis, I considered that as well. And then I said, you know what? This is so early. The bone stock is so good. What if I do a minimal infix and back it up with X-fix? What if I just do a triple on this? And I didn't even do a triple. I actually did a medial column double on this. So that was kind of my thought process, and I've been playing around with doing less if I get them very early. And I've had really, really good success. I think that this has made me such a believer of abandoning that dogma of wait, because you get them early, you can do all this stuff. You don't need to go in there and to ruin this guy's ankle joint. You don't need to make his foot stiff, give him a cement foot. So again, one of the things I always like to point out, and for this it's acute, so it's a little different. His calcaneus is behind the tibia, but also if you look at this angle, his talar declination isn't that bad. It doesn't look like his ankle joint is affected to me. So this is one where I actually deviated from what I normally do, which is if I see the calcaneus behind the tibia, I'm going immediately to a hindfoot fusion. I thought because his talar declination looked relatively okay, we could treat this at the hindfoot. So I did my standard triple, leaving out the calcaneal cuboid joint because it's a bear to get to heal anyway, and I backed him up with a frame. I left him in a frame for 3 months. I always get my CT beforehand. I removed the external fixator. I put him non-weight bearing. I casted him.
So we talked about this a little bit. The original description of that out of Portland called those holding frames, which is kind of what you're talking about. It certainly protects your ankle. In the ones that you have done, how many times have you gotten infected internal fixation?
So,
and by that I'm saying with the Pentrax. So obviously,
I don't think I can think of one off the top of my head that I can definitively say that pin sites were the cause of the infection. I don't see that.
All right. And you showed some experience.
Yeah, I've had one instance where I had I think it was from the calcaneal pin infecting. I did a very similar construct with the exception of I went across the CC joint. He did get infected. His cuboid had dropped too. So only thing I saw in that case was, and on your x-rays you showed you didn't have it, but I was worried about the cuboid dropping. I've made that mistake where I do medial column, subtalar joint, and the cuboid drops, year or two later or something. But I think, I have one that I know of that is probably related to the calc pin, and but that's one out of hundreds. So
yeah.
It much lower than that 40% infection rate we see.
Yeah, my experience is I love it with the foot. A couple of my partners say I don't mind it with the ankle because I can be above and below the rod, but I love it in the foot mainly because I think it protects the ankle, and
right.
I really if I'm aggressive with it, I have less of that disappearing talus that we've all seen. So I think this is great. Now, how long do you leave the frame on?
I left the frame up for 3 months with him.
Yeah.
And then after that, I gave him another, I think, 2 months in a cast.
Correct.
And here we are. This is 18 months. He's in a diabetic insole, nothing else.
Yeah, I mean that looks amazing, and I do think that we're learning if you see him early that you have many more options, because then this becomes a trauma case that you fuse versus a fixed dislocation, which Mike showed that you have to fuse also, but you're going to have to remove some bone to get it to heal, because that looks amazing.
I surprisingly have no criticism of this case.
It's one of those cases where I if you had asked me 3 years ago would I have done this, not only would I have said no, and I can be a little bit bellicose with what I say. I would say that this is absolutely malpractice. You shouldn't do this. But I think we're learning as we go, and we're evolving, and we're constantly evolving. I would have probably have done bolts and beams on this, and then I may have hosed myself on the ankle, because you can't protect the ankle with an external fixator.
Well, what you did is intervene before Charcot, right? And this goes back to our conversation is if you've got a dislocation in a non-Charcot patient, then you're never leaving that alone. So why leave it alone in a Charcot patient and expect it to do well? It's not going to do well. And so what you did is use your non-Charcot program and then added the frame, which I think is what kept it from ever going into Charcot.
Right.
Yeah. And I think he could do this on the rats. Mice.
On the mites.
Yeah.
Yeah.
I'm trying to. Did you ever see that movie Willard?
Yes.
Yeah. I'm looking at you. Going, Michael Jackson's going to sing a song about you.
They are very non-compliant. They will walk on whatever you put them.
That is my experience with rats also.
All right.
It's my experience with Texans, so that's why we have the classic punishment cast. Do you guys use a punishment cast?
Yeah. No.
A punishment cast is a long leg cast with the knee bent to 90 where the top of the cast goes up to the scrotum so they can't cut it off. They beg you to take it off.
Yeah, that is honor of all. Okay, all right. You got another one?
So yeah, let's keep going here. So this is a little different. Again, you have to see this patient. They want to take her leg. I got this this is actually the one that I showed you. I don't have the x-rays, but I'd like to talk about it because I just finished her last night around midnight. So this is what we talk about. This is when you let it get too far. The cat's out of the bag. This was a Lisfranc fracture. That was a Charcot Lisfranc fracture that it's been like this for 8 months. So she had an A1C of 11.2.
In Texas, I would think it would be the steers out of the barn, but
Yeah.
I mean, I guess they have cats in Texas. All right.
Yeah, we got to keep the mice out of the chicken coop. His mice. So again, she was very uncontrolled with her blood sugars, altered sensation, rocker deformity, big ulcer, irreducible. I spent the better part up until last night of 8 months trying to take care of this. And I pre-opted her 2 weeks ago to do this case on this side. But then she came in, let's see, where are we? It's not going, there we go. She came in 3 months after we got her everything done. We're getting her pre-op planned, cleared, her other side. She's got same exact thing, acute Lisfranc fracture. So the reason I bring this up is, yes, I don't have the x-rays and I can show them at a later point or send in slides, but now what the hell do you do? You have one side that she's clearly shown that she can't be braced because she keeps re-ulcerating. And now you have this side that started just like the other side started before she got to me.
Yeah, I mean, Mike, what do you think?
Yeah, so first question would be, right side's now infection-free?
Infection-free. MRI.
Ulcer-free or
ulcer-free, infection-free.
And you have her in a AFO, dumbbell upright, or?
I've had her
Suit
non-weight
cast.
bearing
Okay.
to try to get that ulcer to heal.
This is a tough problem. This left side, you are ahead of the game if you go now. The confounding factor here is she's got to put weight on something, and that being her right side, which is at high risk of re-ulcerating the second you let her start to walk. What kind of 55 is she? Or active or not active? She worker?
She's very active. Her and her husband actually own about 50 emergency rooms in Texas. So they're
So this is probably overly aggressive, but I have several patients that are in the same boat where we're looking to go on the one side, and they come in with a hot dislocation or an ulcer, new ulcer on the other side, and we have to flip the script. And while you're treating that new side, your left foot here, the right side runs into an issue. And I've had it happen a couple times to me. I would treat them both at the same time. And I know that sounds crazy, but I don't let the frames put much weight on, just enough to transfer. And if you think she's compliant enough and she'll go for it, I would actually do, and the right side's going to need a big wedge, and then medial column stabilization with beam bolt or even the midfoot nail. And I would shoot for a triple on the right. And on the left side here, your subtalar joint looks pretty good. And I think if you could probably go past the zone of injury and do either plantar medial column plate and reduce that Liz Frank and kind of just extend your hardware to the navicular. But I would do, if she go for it, I would do double frames, and I'd do them both. So you could handle that. I know you can.
So that was my plan. But my plan was to stage it because I just didn't want to be in the operating room for 8 hours with this patient because I don't want her to get a DVT. She's gonna be immobile. I also wanted to get used to one frame. So my plan was to do the acute one first, which I did last week. And I did exactly what you said. I went from base of the metatarsals up to the navicular. I used biologics. I used iliac crest on her. And then I backed it up with a frame. And the reason I backed it up with
use IM intramedullary or plate?
Plates. Yeah. Plates and screws. And then I backed it up. The reason I didn't use IM is because if I backed it up with a frame and I made the frame strong enough, I can let her walk on the frame. And then I gave her the chance to go home, flip the knee scooter to the other side, the right side, and let her walk with the frame. Last night I took her back. And again, going back, and this is where I disagree with you. So if you look at the
Kane angle,
the blue line,
heard it here first.
and you look at where her talus is versus where her tibia is, and her ankle's involved. Yeah. It's got to be involved. And I went to the operating room. We did this one last night on this side, and my plan was to do a hindfoot fusion with the frame. But when I got in there, because everything was at the Liz Frank interval, the hindfoot was incredibly good bone quality. And when I prepped the joint, I did a subtalar sinus tarsi incision, and I did an anterior incision. And when I went on that anterior incision, the ankle, I put laminar spreaders in, and you can gap it a good 3 centimeters. Yeah. I would have gotten hosed if I had tried to leave the ankle alone. So what I did was I wound up doing a triplanar osteotomy at the transverse tarsal joint, do a hindfoot fusion with the nail, and keep her non-weight bearing on this for 2 months. And I told her, really, I said 11 weeks.
You didn't put a frame over the top of it?
I did not. I didn't think I needed to because we got such good fixation and the bone quality was so good.
Yeah, I think I like that doing the acute stage first. I would use intramedullary with MIS, just taking the joints down, squirt a little augment into it. And you don't, it's the one time you sometimes don't have to go across the tail and navicular joint, and you may be able to save the hindfoot. And I would definitely put a frame over that because I think it saves your ankle. This I think is dealer's choice because you've got such good bone, and the nail alone probably is reasonable. But adding a frame, I wouldn't hesitate to, mainly because of the previous ulcerations.
Yeah.
And
I actually took a poll in the OR because I hemmed
it was
hard.
midnight. If you take a poll at midnight and you ask them whether to do a frame, 100% are going to say, no, it's good. Go home to your pregnant wife.
It was the frame or the nail. I wasn't gonna frame over the nail. So I said it'll take me about 40 minutes to put the frame on. It'll take me about 30 minutes to put the nail in and do everything else that needs to be done. And the resident who was with me, there's a podiatric resident who comes every now and then to learn some of these Charcot cases, said, why don't we try to do the nail? You put the frame on the other side. It's going to be much easier for her, even with the rolling knee scooter. And If it works, it works. I could tell you I saw her this morning at 5:30, and she was tickled. She could not be happier that she did not have a frame on that side, but also she saw her X-rays and she was like, "My foot's straight. I haven't arched my foot again." So
Yeah.
we'll see.
Frame, people are tickled when they don't have a frame, especially if they've had one before.
Yes.
Yeah. And that's the hard thing with the frame. We know it works, we know it helps, but yet people are so happy when they don't have it, but they also know that it saved their leg multiple times. And so I have a couple of those patients on speed dial when my nurse calls. All right, what you're going to do is talk to this patient because you have to put this frame on and know that this can save your leg, because they went to multiple different people before. They've had multiple operations, and until they get the frame, yeah. And the frame needs a good PR firm.
Yes.
Don't you think?
Couldn't agree more.
I make them hold it in my clinic because we have frames in every room. And I'll say, "I want you to hold this. I'll be back in about 5 minutes." And you and your wife talk about, or you and your husband talk about what this is.
So you get them to cuddle up around it.
I give them a little blankie, like a 2-person blankie.
A frame support group.
The frame support.
We have those.
Yeah.
Call this guy. He had a frame. He's got his legs.
Yeah. It is one of these things that if you're going to take care of these folks, you have to do frames. And the static frame for me is the standard. And with a good assistant, the salvation frame you can do in 20 minutes. Really, if you don't have to build up and you have it pre-built and all that, but it's still 20 minutes. At least once you put the frame on, everything else is closed, and so you're all right. That's great. This is a great dilemma, and this is the kind of stuff we're talking about, right? That if she shows up in a general surgeon's office, she's got an amputation on the one side, and the other side's going to go bad. You've seen it, right? You've been trying to protect her. Now she's got on the other side, she goes to the same doctor, she's got bilateral BKAs, and we're talking about obituaries. I just think this is great stuff. Hard patients. I mean, the fundamentals aren't that hard because we have better, but it's great stuff. All right, one more case.
One more case. Very similar to what we've seen before. A 52-year-old male, acute onset of deformity, redness of the left lower foot. So looks maybe even a little less deformed than the other peritailars that we've seen, but this is a peritalar dislocation. You could see the calcaneus is sitting on the side of the talus. Talar navicular joint is subluxated. So I seen it, and I've done these. So it's worked before. Why won't it work this time? So not much different except he's type 1, not type 2. Well-controlled diabetes, insensate, no ulceration, no callus. He's mobile and reducible. So I think that this is something that fits that algorithm. You can go in early and maybe save the ankle joint. So it's the same algorithm. Do you do isolated internal fixation and span the entire foot? Do I do a flipper foot? Do I do a hybrid fixation? And I went for the hybrid fixation again because it's worked for me, and I've done really well with these. I've done a bunch of these now, and I thought he would do well. So no different. It's the same exact construct that I use. It looked good. CT, when we did it prior to removal of frames, showed most consolidation. And then non-weight bear them in a cast until you get them into whatever their brace is going to be, Arizona, Ritchie, double upright, whatever is going to be accommodative to them. And everybody's different. We all know it. You send somebody for a double upright, it doesn't work. You got to play around and try to keep them out of a crow. So here he was. This is about 8 months later. It looks great. But, you're not always winning. So he called me on Sunday night, like it was still football season because I was on the couch watching football. And he said, "Doc, I thought you were supposed to fix my foot." I was like, "Oh, God, what's going on?" And he's like, "I have a consultation this week to go see somebody for a total ankle replacement." I was like, "Well, let's back up. What's going on?" He's like, "I feel a lot of clicking in my ankle. My ankle's painful." I was like, "Well, you're not a candidate for a total ankle, and anybody who's going to recommend you a total ankle, can you please tell me their name so I can stop them from maiming people? If you have a problem, come to my clinic and let's talk about it." So he did. And there he is. And he fell apart at the ankle.
Oh, boy.
So we are now at a point where he doesn't really want any more surgery. So I made him a crow boot to see if I could at least keep his ankle stable.
Was he grossly unstable?
He was not at that point, but here he is 4 weeks later.
Yeah.
So now what do we do? Because I have him coming back to my clinic next week. I thought we did great. I thought my triple was going to work. It looked like it worked on CT. He had 8 months of success. What do we do?
I think you have enough posterior tibial plafond to salvage this still, but it's going to be a home run swing. And I would take all that out, two-stage the heck out of this. Probably would go in and take all the hardware out, culture, make sure you don't have an infection on your hands, because that went away pretty quick. While it's probably Charcot, because you haven't given us any indication it is infection, that went fast. And so take it all out, culture. If it's negative, come back, iliac crest, ton of it, pack it in there, chamfer cut in the posterior tibia, frame them, and then I'd probably come back and
Rod in a frame or just a frame?
I have trouble with where fixation is placed on some of the nails. I would go large, fully threaded screws out of the Charcot in multiple directions with the frame on top, kind of like that one case I had in the intro lecture with iliac crest graft. And I think if you keep in the frame long enough, you'll save this leg. That's bad.
Yeah,
What'd you do?
That's what I want to know. I
It's
want to know what I
the
did.
disappearing talus, and for a while the angle of Kane, told you, but I didn't think that the talus was that plantarflexed, and I think that was a reasonable approach. And sometimes this just happens, and I don't know, but I will say that it's worth. I've saved all of mine that this happens to, and when the fellow go, man, we're on a roll, we're doing great, I love and I go, let me show you this file, right? And it would be worth putting all of our cases together with the disappearing talus and see if we could figure out what the risk factor is, because if you do enough of these, you see this, and I don't think it's too stiff, right? Because you left the transversal, you left the midfoot fine, yeah. But I think it's salvageable, but again, they're short and it becomes different, and there's no role for a total talus here, don't you think?
No, but I was going to ask you guys want to do a total ankle for me? I can send them out to you.
Yeah, boy.
No, sir.
Yeah, boy. I'll show you as we get through the course. One of mine, my total ankle on a neuropathic, just a cautionary tale. Well, it's great. And this is, I love the fact that two near identical cases, but yet with a different result. And that's why this is a challenging patient population. But it also means that we need to keep our best guys on it, right? I think we really need to have that. I'm super pleased that Stryker has supported the efforts to design around this space, because we've got to have that support. Now we have the best tools that we've ever had to do that, to save these folks' extremities. All right. Well, we're going to come back with a lightning round to finish this up.
Get the robots.
All right.
Boom.